Thank you. Okay, welcome everybody to Equine Dermatology. It's pretty difficult to try to cram in the entirety of equine derm into 2 lectures, so we're basically going to be taking a cruise ship approach for this, just a few minutes on many different topics in order to provide a taster for the breadth of equine derm. So I am Bill Oldenhoff, and I will be seeing you all in clinics next year, because I'm assuming you're all taking dermatology. So we're taking a problem-oriented approach. When you're talking about any subject matter, I think that the best way to approach it from a clinical standpoint is to identify what the basic problem is, figure out your list of differential diagnoses for that problem, and then do the appropriate diagnostics from there. The textbook that I would recommend if you're going to be doing any kind of equine derm is Equine Dermatology. Recently came out in the 2nd volume by Danny Scott and Bill Miller. It's a good book, has lots of pictures, lots of flow charts. It's very easy and simple to use. So what are the basic problem categories? Depending on what source you read, there can be anywhere from 6 to 10 different basic problem categories. The way that we're going to organize these are according to this. So pruritus, crusting and scaling, ulcers, erosions, lumps, bumps, discoloration of the hair and the skin, and then hair coat changes. I often joke with the students that if you can obtain a list of differentials, if you can obtain a diagnosis before you even see the patient, that's really ideal. And that's only a half exaggeration. Basically, identifying what the primary problem is about 50% of your diagnostic problem or diagnostic course when it comes to dermatology. So I think it's important to remember that what the client brings the animal in for is not always actually representative of what the actual primary problem is. So it's important to do a really thorough history. You cannot overstate the importance of a thorough history when it comes to dermatology, and then that will be able to point you into the direction of what problem category you will be going into. So the diagnostic techniques for equine derm, they're basically the same as what you would do in small animal dermatology. So Dr. Morello says we can practice out of Walmart, and that's basically true. We use slides, we use tape, and we use microscopes. Skin scrapings, hair combings, those are done to look for mites, lice, different parasites. Acetate tape preparations and impression smears, that's for direct cytology to look for like bacteria, for yeast. And then, of course, bacterial fungal cultures, skin biopsy, and dermatophyte culture. I don't really need to explain those, I would imagine. So the most common reason that a horse is going to come in for a dermatologic problem is going to be pruritus. The various causes of pruritus are here listed on the left. And of these, the most common are mites, lice, insect bite hypersensitivity, and contact reactions. So without further ado, we'll go ahead and get started. So Coreoptes is a contagious mite, and it presents initially with pruritus of the lower legs, and then from there it can become generalized. Coreoptes is a big fan of horses that have nice feathered fetlocks, so they really like to infest draft horses. They also will jump species, so you'll see these on cattle, you'll see them on small ruminants, you'll see them on llamas, alpacas. They don't like to go to humans, so if all the humans in the environment are affected with a rash, maybe Coreoptes should be a little bit lower on your list. And the picture here that you see is kind of characteristic for Coreoptes. So you can see the horse has really nice feathered fetlocks above the areas of severe self-induced excoriation. When you suspect Coreoptes, you should do multiple skin scrapings. They can be really hard to find, so multiple skin scrapings of multiple legs is really important. And then the treatment for this mite is ivermectin for all in-contact animals. The symptoms for Coreoptes, they are very dependent upon the sensitivity of each animal. So you can have some animals that are asymptomatic carriers, so it's very important that everybody be treated. These mites can actually survive off the host for about 70 days, so eradication of them from the local environment is exceedingly difficult. you need to treat everybody in the environment. You need to clean the environment thoroughly, apply topical pesticides to the environment. And even then, often what you're hoping for is just reduction in the total numbers of mites, not so much eradication in many cases, because it can be almost impossible to actually eradicate these mites from the environment. So, and here is a picture of the little bugger, and this one was found on a llama alpaca hybrid that we had down in the clinic a few months ago. Oh, you know what? And I should mention this before I forget. This is a large pile of notes that I typed up for you guys. You're not going to be tested on the entire breadth of everything that's in here. The stuff that we're going to be testing you on is actually what's being talked about here. So this is something that, if you so choose, you can hold on to it and keep it as a souvenir. All right, let's move on to the other mites. So Sarcoptes scabiei is rare and it is reportable, and it causes very intense pruritus of the head and then can become generalized. Cross-species transmission is very common. So scabies, as you know, likes to jump ship. It likes to go to other animals. It likes to go to people as well. So if all the people in the house are very itchy, this should be one of the things that you think about. They are very, very difficult to find on skin scraping. Usually, if you're going to find it, you're going to find it at the margins of the ear pinna. So again, multiple skin scrapings to try to find this mite. Certainly in dogs, you only find it about 20% of the time when animals have it, and that number is about the same for horses as well. So basically, if you suspect it, if you have a bunch of animals that all have very severe pruritus of the head, owners are itchy, you basically are going to treat everybody in contact with ivermectin, and then response to that just tells you that it's an ivermectin-responsive disease. It doesn't tell you if it's scabies, it doesn't tell you if it's Sauroptes, it doesn't tell you if it's lice, et cetera, et cetera. It just tells you some sort of parasite that got killed by the ivermectin. And here you can see, of course, there is Sarcoptes scabiei on the right. And then the other contagious mite, which I didn't have a picture of, sorry, is Sauroptes. And this is the head and trunk mite of the horse. So it causes head shaking, kind of drooped ears. And on the trunk, it can cause pruritus, crusts, and excoriations. And Sauroptes also, it does not cause human disease, so that's one good thing about that. But again, all in-contact animals should be treated. It also can be difficult to find, so if you suspect it, you should do ivermectin for all in-contact animals. And if anybody has any questions or anything, you can feel free to raise your hand. All right. All right. So we'll talk about lice. So proliferation of lice is aided by colder weather and overcrowding. Lice particularly like to hang out on older, younger, debilitated animals. And the symptoms that you're going to see are pruritus, restlessness, poor hair coat, alopecia, and of course the alopecia is secondary to the self-induced excoriations because of discomfort, and then the self-trauma. So what you're going to find are the nits, which are readily available for macroscopic viewing on the hairs. You basically pluck hairs on the affected parts of the body, and you can identify the nits right on the hairs. There are two main species of lice that are of concern in the horse. So Damolinia equi is the biting louse of the horse. It particularly is a problem on the dorsolateral trunk and tends to be fairly mobile. And then Hematopinus acini is the sucking louse, tends to live on the mane, the tail, the fetlock, and is stationary. With lice, all in-contact animals, again, should be treated. That's kind of a recurring theme with these parasites. And there are all sorts of topical medications. Ivermectin certainly works. Lime sulfur might work. Fipronil spray can work as well to take care of lice. And moving right along. So Trembiculiasis, chiggers, are a free-living mite. The nymph and the adult stage of this mite are free-living in the environment. It's only the larval stage that is actually parasitic. So the symptoms that arise are papules, wheals on the distal limb and muzzles, and that makes sense, right? Because that's where where the horses are going to be in contact with the ground. So the symptoms are very seasonal. Tends to be late summer, fall, which coincides with emergence of the larvae from the environment. So these larvae are very, very small, 0.2 to 0.4 millimeters long. And so in some cases, you can actually see the larvae in the lesion, but basically what you're just going to see is a really tiny little orange dot. Sometimes, because it's so seasonal, because it's usually self-limiting, treatment is often not done, but in more severe cases, you can do treatment as you would for lice. And so there you can see the bright red. That's the adult stage, actually, on the right. Okay, pinworms. So pinworms in the horse are caused by Oxyurus equi. This is not the human pinworm, so your kids are not going to get pinworms from your horse, and your horse is not going to get pinworms from your kid, which is probably a good thing. The main symptoms that you're going to see with pinworms are anal pruritus. So you can see this horse here has the alopecic area at the base of its tail, and that's from tail rubbing. So differential diagnoses that you might have for tail rubbing include lice, mites, stall vice. So if you suspect pinworms, what you should do is take an acetate tape sample and basically apply it to the perineal area. The adult female worm will basically crawl out of the rectum and cement its eggs in the perineal area. So you take tape, just apply it to the perineum, look at it under a microscope, and the egg sacs are readily available, or readily visible. And they don't really cause much of a problem internally. They're not terribly pathogenic, but they do cause just this symptom of tail rubbing, of restlessness. So basic hygiene has made this disease, or this worm, a lot less common, actually, than it used to be. So any of the basic dewormers that you'd use for strongyles will work for pinworms as well. So we're going to move into the biting flies. So the picture here, that's a big, juicy horsefly. Horseflies, deer flies, those are in the tabinid family. And these are big flies, and they produce individual strikes. So rather than swarms of flies that produce small little strikes, these are usually individuals. The feeding areas of preference for the tabinids are the ventrum, the legs, the neck, and the withers. And these flies are extraordinarily difficult to control. Because they're very strong flyers, you can't put up fans to prevent them from flying around. And you basically need to apply frequent fly repellents to your horse. One thing that's actually very helpful is that these flies have approximately an 8-day life cycle, and they often like to reproduce in manure. So if you have manure on the farm removed about once a week and taken off-site, that can actually do a lot to control the biting flies. Stable flies, Stomoxys, these also produce individual strikes, and they are on the neck, the back, the chest, the groin, and the legs. And then control measures for Stomoxys would be basically the same, so frequent application of insecticidal repellents and removal of manure once a week. All right. And the horn flies. So that's a horn fly on the right. These are small flies. They're about 2 to 4 millimeters in length, and they are a potential cause of ventral midline dermatitis. So horn flies, their feeding preference site actually varies by the weather. So in cool, rainy conditions, they will preferentially feed on the ventrum of the horse. So ventral midline dermatitis is just a reaction pattern in the horse that is characterized by these very sharply demarcated areas of alopecia on the ventral midline, obviously. And then in contrast, when you have... Wait, did I said cool, rainy weather, they like the ventrum, didn't I? Sorry. Sunny, hot weather, they like the ventrum. Cool, rainy weather, they actually like the top line. Sorry about that. And then horn fly control is easier than some of the other flies because once they land on a host, they will rarely leave. So daily application of a fly spray will usually do a pretty good job of controlling these guys. Black flies are tiny little guys that are a significant nuisance. They are a vector for various viral protozoal diseases. And basically, they produce papules, wheals. Large swarms of them can cause generalized symptoms of dermatitis in the horse. And the control measures for them are quite difficult. Frequent fly application or fly repellent application is of benefit, but ultimately control is very difficult for these guys. And mosquitoes, you guys are no doubt familiar with here in Wisconsin. They are also vectors for different viral filarial diseases, and control measures for them. You can try different mosquito traps. Those have been met with middling sort of success. You can also do environmental control, so eliminate standing water on the environment. So we're going to move on to insect bite hypersensitivity. Insect bite hypersensitivity is the most common allergic skin disease in the horse, and it is caused by hypersensitivity reactions to Culicoides fly saliva. So you can see Culicoides are these tiny little flies here on the right. There's sometimes cross-reactivity observed with the saliva of other flying insects, but it seems to be the Culicoides fly that is of principal importance. And there are many different species of Culicoides that are potential causes of this. And so different species have different feeding preference locations. So the pruritus, the symptoms, it varies in intensity according to the local species that's causing symptoms, as well as the sensitivity of the horse in question. So insect bite hypersensitivity, like other allergies, has a genetic component. Certain breeds are overrepresented. What I think is really interesting, actually, is that Icelandic horses are overrepresented, and it's interesting because in Iceland they actually don't have Culicoides. So if you have an Icelandic horse and it stays in Iceland, it'll be fine, but if you take it elsewhere, then it has a high chance of developing insect bite hypersensitivity. So here are the symptoms that one can observe with insect bite hypersensitivity. On the top left, that's actually a horse that has ventral midline dermatitis. So certain species of Culicoides are also a potential cause for that reaction pattern. And you can see that it is very sharply demarcated. And so on the bottom left, you have a horse that has facial alopecia, which is, of course, secondary to self-induced trauma. And then on the right, you have the horse that has the shortened barbered mane from self-induced trauma. So the diagnosis for insect bite hypersensitivity is mainly on history and physical exam. Blood allergy testing, intradermal allergy testing is of very limited utility for diagnosing insect bite hypersensitivity. And the goals of treatment are, of course, try to limit the access that the horse has to the flies. So that involves stabling the horses during the peak feeding hours, so from dusk until dawn. These flies are really small. They typically will not enter buildings. So if you can stable the horse kind of in the center of the building, away from doors, away from windows, that can help. Fans can provide a lot of relief as well. Horses are usually fairly smart about this and will learn fairly quickly that if they stand under the fan, they're not going to be bit by the Culicoides flies. Culicoides do require water to hatch, and they don't fly usually very far from their water. So if you can eliminate like drainage ditches on the property, that can help as well. And then for actual medical treatment for the horse, antihistamines have very limited use in the horse. Basically, they can at most take the edge off a horse's symptoms, but they're in most cases not going to actually be the principal cause of relief for the horse. Their main utility is as a steroid-sparing drug. So steroids are reliably the most effective way to control the symptoms of insect bite hypersensitivity. And that's fine when you have a horse that has very, kind of a short allergic season. The problem is, of course, with chronicity, overuse of steroids leads to all sorts of problems in the horse, including laminitis, which is obviously a problem. you're probably wondering, based on your small animal derm lectures and hearing about allergy shots and immunotherapy, whether this is a viable option for insect bite hypersensitivity. And the studies that have been done have been kind of conflicting. Basically, there's no standardized protocol. So right now, allergy testing and allergy shots for insect bite hypersensitivity cannot be recommended. So it's mainly steroids, antihistamines, and then limiting the horse's access to the different flies. And then horses do, of course, get the other allergies that we see in other species as well. Food allergies are pretty uncommon, pretty rare in the horse. They're probably actually even more. They're probably somewhat underdiagnosed because in the horse it's really hard to do appropriate elimination diets. It's not like in the dog where you have these really nice hydrolyzed or novel protein diets that are commercially available. With the horse, you have to find specific forages that the horse has not been exposed to and feed it that. And then when you're talking about elimination diets, in addition to whatever forages the horse are receiving, you have to also take into account the different treats, the different supplements the horse is receiving. So food allergies, thankfully, they're really rare, and they're really hard to deal with in the horse because of the diagnostic dilemmas. Contact reactions. Irritant contact reactions are really common in the horse, but true immunologically mediated allergic contact reactions are fairly uncommon. Sorry. And then atopic dermatitis. Horses get atopy just like dogs do, just like people do. You can have regional pruritus of the axillae, the groin. It can also be generalized as well. Again, just like any other hypersensitivity, it varies by the degree of sensitivity of the horse. The symptoms that one sees with atopic dermatitis in the horse include generalized pruritus or urticaria. So urticaria, I'll talk about that and show some pictures in just a moment, but basically those are wheal formation, which is sometimes pruritic and sometimes not pruritic at all. It can often be very dramatic, and it's shocking to see a horse that has these very generalized wheals and to think that the horse is actually not pruritic, but that is the case. And atopic dermatitis, just like in small animals, is a diagnosis of exclusion. So you find out what are the possible causes of pruritus in the horse. So, of course, parasites are one of the big causes. So you have to rule out all parasites, make sure infections are not a complicating factor. And then if your horse is pruritic, despite ruling out all of those things, it's some kind of allergy. And then you just have to use your diagnostic skills to eliminate food allergy or disregard it potentially, and then proceed with either atopic dermatitis treatment or maybe insect bite hypersensitivity treatment. So the way you treat atopic dermatitis in the horse is as in small animals. So you have antihistamines available, which again, they take the edge off, but they usually don't provide significant relief. You have steroids, but because of the more chronic nature of atopic dermatitis and the fact that it's often year-round, steroids are not usually a viable option for long-term control of a horse's symptoms. So immunotherapy is the way to go. It's clearly the best thing for the long-term health of a horse. You can do immunotherapy allergy shots based upon blood testing, based upon skin testing. The skin testing is considered to be the gold standard and is more studied, but the blood testing does have utility as well. And the success rates that we're looking at are between 70 and 80% success with immunotherapy. So things to keep in mind with allergy shots are that it doesn't start working right away. So after you test and formulate the shots, it requires basically a 1-year trial to determine if the horse is going to improve. And then as I said, it doesn't work in every horse. So the odds are between 70 and 80% or so. And you do the intradermal testing on the horse by shaving an area on the side of the neck. And are you guys able to see that very well? Okay, good. And basically, you do a negative control, so that's top left is negative control, and then a positive control, which is histamine, and then you inject all your allergens, and you measure response of the horse in comparison to the negative control and the positive control. So you can see this horse has some really nice reactions. So a few notes about urticaria. Urticaria is a reaction pattern that occurs because of any number of hypersensitivity reactions, drug reactions. I'll have a list up in just a moment that talks about all the different possible causes. But basically, the wheels of urticaria, they should pit upon pressure. So you should be able to apply pressure to these wheels, and they should be able to actually pit. They are variably pruritic, so sometimes they're itchy, sometimes they're not. And then typically, the wheels for urticaria will go away within a few hours. So if it's persisting for a few days, a few weeks, you should have in your mind that there might be something else going on, and you should be considering biopsy. So here is a horse with urticaria. So you can see that is quite dramatic. So it's hard to believe that a horse can look like this and not actually be pruritic, but that can be the case. And then here are some of the different causes for urticaria. So hypersensitivity reactions, so any of the allergies can lead to urticaria. Drug reactions can lead to urticaria. There's a class called physical urticaria, which is interesting. So cold-induced urticaria can be tested by taking an ice cube, placing it on a horse for about 5 minutes, removing it, coming back a few minutes later, and if a wheal forms where the ice cube was placed, that is diagnostic for cold-induced urticaria. Dermatographism occurs when you apply moderate pressure to a horse, or an animal, or a human, for that matter. And after you apply moderate pressure, within a few minutes, you get wheals that form where you applied the pressure. And then exercise-induced is fairly self-explanatory. Stress-induced urticaria, I guess whatever that means. It's known that stress can cause exacerbation of dermatologic disease in other animals and people, so it's probably related to that. And then vasculitis, arthropod bites, and stings can also lead to urticaria. So I think when you have a list of differential diagnoses that's this broad, the important thing is trying to figure out what the actual underlying cause is, and that's really the challenge. So again, a thorough history is of utmost importance. Finding out what drugs have been administered to these horses, if anything has changed with regard to food for these horses, just going through the list and trying to narrow it down. All right, so we're going to move on to the other problem categories. So dermatophytosis, dermatophilosis, staph, malassezia, demodex, pemphigus, sarcoidosis, and seborrhea. Those are the big causes for crusting and scaling in the horse. So dermatophytosis. The 3 species of utmost importance in the horse are Trichophyton equinum, Trichophyton mentagrophytes, and Microsporum gypsum. And dermatophytosis in the horse is common, and it is, of course, contagious. Just like in cats, it tends to be more of a problem in animals that are either very young or very old. It's also aided by overcrowding and poor housing. And it causes crusting, papillary eruptions, alopecia, and variable pruritus. And you can see the horse here on the right has the very characteristic lesions of dermatophytosis. Differential diagnosis for this, of course, would be all the different other causes of crusting and scaling. So here on the right, we have the classic Trichophyton. On microscope, you can see the very characteristic spiral hyphae that you see with Trichophyton. So you diagnose this by doing fungal culture, and skin biopsies of limited utility. You're going to be diagnosing it by fungal culture. And the horses are unique in comparison to other small animals because horses clearly live in environments where there are large numbers of saprophytic fungi that are present. So it's easy if you do a fungal culture to get over too much contamination of the plate. So one thing that you can actually do is gently wipe down the area with a little bit of alcohol prior to taking your fungal culture, and then plucking hairs, doing your toothbrush samples, inoculating it into DTM, and basically waiting 3 weeks or so. Most cases of dermatophytosis, they'll grow within 1 to 2 weeks, but it's good to keep these plates on hand for 3 to 4 weeks because some species of Trichophyton can grow pretty slowly. And then the treatments are topical lime sulfur, There is successful treatment with enilconazole as well, although this has been this is an off-label use of an EPA-registered product, so there is concern about liability issues with that. But lime sulfur is the safest, most reliably effective treatment for dermatophytosis available. In cats, we do systemic treatments as well, but in horses, systemic treatments aren't really viable options. So horses don't absorb the azoles. So ketoconazole, for example, is not absorbed from the GI tract. Greaseofulvin is not effective. So it's really topical lime sulfur and then environmental decontamination. You want to make sure that when you're removing these crusts, when you're cleaning the horse, that these crusts aren't just going right into the environment where they can serve as contaminants for other animals. You need to actually be able to dispose of them in a sanitary fashion. And dermatophilosis, rain rot, caused by Dermatophilus congolensis, which is a lovely filamentous bacterium. So dermatophilus requires 3 conditions in order to proliferate and cause infection. It requires chronic moisture or chronic rewetting. It requires skin damage, which can be either due to trauma or due to maceration of the skin from moisture. And then the most important source of infection are carrier animals. So you can have animals that are asymptomatic carriers of this. It produces these very characteristic paintbrush lesions, so you get hairs that are easily epilated, and you get this clump of hairs that are all adhered to each other with these very thick crusts. So it is really, it looks like a paintbrush. And then the skin under the crust is moist, exudative, eroded. It's often painful when you epilate these, so be careful. Don't epilate large amounts at one time. The diagnosis for this is with direct cytology. So you can take crust and do direct impressions of the underside of that crust onto a slide, stain it, and I'll show you what the characteristic appearance of this organism is. And you can also do crust preparation. So if you take a crust and you put it on a slide with a little bit of sterile saline, macerate it, let it dry overnight, stain it the next day, that can also allow you to identify the organism. So because this bug requires certain conditions for it to proliferate, treatment is really aimed at those things. So, number one, get the horse dry. Don't subject it to chronic moisture, to chronic rewetting if possible. Remove the crusts. So again, removal of these crusts can be painful, so you often need to use a little bit of general sedative. When you remove them, again, same as dermatophytosis, do that in a sanitary fashion. Don't throw them into the environment where they can be a source of infection for other animals. Dispose of them in a very sanitary manner. Systemic antibiotics can be necessary in more severe cases, but usually just eliminating these 3 conditions is going to do it. And then this condition can be chronic. So it doesn't cause, infection does not cause lasting immunity, and in fact, animals that get infected might be more predisposed to reinfection. So you just have to be aware that there can be chronic carriers in the environment. So here is a horse with dermatophilosis, and you can see the clumping lesions. You would be able to epilate those pretty easily. And then here is the characteristic cocci in a branching railroad configuration. There aren't really too many other things that look like this on cytology. Right. Okay, moving on to bacterial pyoderma. So when we're talking about bacterial pyoderma, we're really talking about coagulase-positive staphylococcal infection. And the 3 species that are of most importance in the horse are Staph aureus, Staph hyacus, and Staph delphini. Staph delphini is part of the Staph intermedius group, which you probably also know consists of Staph pseudintermedius and Staph intermedius. And the branching of that family occurred fairly recently in the literature. So what you might find is that if you read some of the older literature, they might refer to Staph intermedius in the horse. And in most cases, that's actually thought to be Staph delphini. It's kind of like when you're reading about pyoderm in the dogs, and it's understood that if it was Staph intermedius before, it's probably actually referring to Staph pseudintermedius now. So the lesions that are caused by coag-positive staph are circular crusts, which are called epidermal collarettes. papules, and pustules. And it's important to remember that these are normal components of the skin. This is normal flora, so something has to go wrong for it to proliferate and cause infection. And sometimes that can be a very simple one-time event that once you treat the infection never recurs. It can also be a chronic underlying problem like an allergy or an endocrinopathy. So one of the patterns that we see is folliculitis of the saddle region, and of course that's just secondary to the microtrauma associated with saddle wearing. Pastern folliculitis. So pastern dermatitis is a pattern of dermatitis in the horse that has a multitude of different causes. So chorioptes, as I mentioned before, dermatophilosis can do it, dermatophytosis can do it, other mites besides chorioptes can do it, lice can do it. So it's very common to have a staph infection superimposed upon any of those underlying events. So if you see a staph infection, treat that, but you have to be aware that there's probably something else that's going on that you need to identify and address as well. And then the story is kind of the same with tail pyoderma in the horse. There are a multitude of different causes for tail and perineal dermatitis, so you have to identify those possible causes. So insect bite hypersensitivity, food allergy, atopic dermatitis, lice, mites, pinworms can all cause tail or lead to tail pyoderma. So this is basically a clinical diagnosis, but culture can be indicated if there's any question that it's actually a staph and not another kind of bacterium. Certainly cytology helps confirm the diagnosis, where you're going to see other characteristic neutrophils with intracytoplasmic cocci. As you can see on the top right, you can see that neutrophils filled with bacterial agents. When it comes to treatment, topical therapy is always the best therapy when it's feasible. So basically what that consists of is chlorhexidine is our favorite product, applied either once a day or a few times a week, depending on the severity of the nature or the severity of the lesions, until you get remission. Systemic antibiotics are indicated in cases where the horse cannot be bathed. You can't have topical application because it's maybe more generalized. Or maybe the owner is just flat out, unable to do any kind of topical therapy. But basically, as I said, topical therapy is always best when it's feasible. And the reason is that, more and more we are dealing with methicillin-resistant staph. So methicillin resistance is conferred by an altered penicillin binding protein. This is encoded on the staph chromosomal cassette. And it's common for these staph chromosomal cassettes to also have resistance genes for other antibiotics. So it's common for these to be multi-drug resistant strains. And of course, in the horse, it's a big problem because horse carry Staph aureus. So that's the human staph that we all worry about. So it's known that equine veterinary staff have a much higher carriage rate for MRSA than the general population do. So that means that there are risks for in-contact horses, in-contact people. And so what you should do is culture early, culture often. Yeah. Sorry, say that again. Oh yeah, absolutely. Yeah. If you have an owner that just doesn't want to do topical therapy, maybe because they just don't like the idea of doing daily application of topicals, you I think are required to bring up that we're not doing this just to provide punishment for the owner, right? We're not doing this just to be as difficult and onerous as possible. We're trying to do this for the long-term health of not just the horse, but also the humans that are in contact. Because obviously, as this indicates, if you have a horse that is a MRSA carrier, that is not just a problem for that horse. That is a problem for any person that's in contact with that horse. So culture early, culture often, do topical therapy when you can. Malassezia in the horse. The exact species of Malassezia that is in the horse is not exactly known. There are probably multiple different Malassezia species, but it's not known specifically which ones. And it is generally considered to be an under-recognized problem. You get scaling, you get variable pruritus. A common pattern that is observed is a local Malassezia overgrowth between the mammary glands, particularly in nursing mares. And basically, you diagnose it by cytology. Malassezia can cause a kind of greasy sort of dermatitis, but really, you need to be able to see it on cytology to diagnose it. And the treatment, as I said, with dermatophytosis, there aren't really systemic antifungal options that are good in the horse. So topical therapy is the way to go. So you can do miconazole, chlorhexidine-based products, and that usually works pretty well. Topical ketoconazole will work well also. All right, demodicosis. So Demodex is normal flora in the horse. So you're probably tired of hearing this, but Demodex, it's normal flora. So again, something has to go wrong for it to proliferate. Thankfully, clinical demodicosis is actually rare in the horse. And when it's present, it causes follicularly oriented scaling and alopecia. And it can start on the face, neck, shoulders, and forelimbs, but it can become generalized. So again, it's secondary to some underlying trigger. That can be a systemic illness. That can just be chronic long-term steroid use. And Demodex in the horse, it's a little bit different from in the dog. Demodex treatment is actually not often attempted. The reason being that most horses are actually asymptomatic for their demodicosis. It can spontaneously resolve without any kind of treatment. And historically, the Demodex has actually been refractory to treatment. There's a single case in literature of a horse that resolved after 15 days of ivermectin, but based upon what we know about Demodex and the treatment for it in other species tells me that 15 days of ivermectin isn't going to do it. It's probably a spontaneous resolution case. And so there you can see it's deep skin scrapings that allow you to identify Demodex, and it's kind of hard to see on this slide, but there's one and there's the other. So they're a little bit more shorter bodied than the Demodex that you see in the dog. All right. And pemphigus foliaceus. Pemphigus is an autoimmune skin disease, and it is characterized by autoantibody formation to components of the desmosome. So remember, desmosomes are basically the protein structures that hold keratinocytes to each other. So the body is attacking the glue that holds the skin cells to each other. So the primary lesion of pemphigus are these intracorneal pustules, which basically are just, as I say, they're pustules, so they're filled with neutrophils, and then you have these free-floating acantholytic cells in these pustules. Acantholytic cells are keratinocytes that, when freed from their attachments to their neighbors, kind of balloon up into these deeply basophilic cells. So these blisters, these pustules are actually very, very delicate, so they rupture. And when they rupture, they produce severe crusting, and it can be localized to the face and the limbs, but then it can become generalized from there. When you have lesions that involve the coronary band, that can create significant lameness issues in the horse, and you can also get peripheral edema. Definitive diagnosis for pemphigus is, of course, with skin biopsy. You can do cytology and see large numbers of neutrophils, conspicuously absent staph, and you can see these acantholytic cells as well. But really, for definitive diagnosis, you need to do a skin biopsy. And then in any case where you are worried about pemphigus, you should always do a fungal culture. The reason being that trichophyton can sometimes form an acantholytic form of infection in the horse that can look very, very similar to pemphigus. So obviously, when you're talking about the treatment for pemphigus and you're talking about immune suppressive doses of steroids, if it is indeed a ringworm species that's causing it, immune suppressive doses of steroids are going to cause some very significant problems, right? So the treatment that you would do in the horse, as in small animals, is with high doses of corticosteroids. So we're talking about prednisone at a dose of 2 to 4 milligrams per kilogram. So that is not the anti-inflammatory dose, obviously. That is much higher than that. And in the horse, we're often limited by costs. So it's a big animal, so the medications are more expensive, obviously. We sometimes will use steroid-sparing drugs in the dog, but unfortunately, those options are very limited in the horse because they are extremely, extremely expensive. So steroids are going to work reliably well at getting remission of the lesion, remission of the condition. But you're often going to be limited by the long-term side effects of the steroids, the cost of treatment, and the fact that many of these horses will relapse as well. But thankfully, it is rather rare in the horse. So here is a horse with generalized pemphigus, and you can see all of the very, very significant scaling this guy has. And then here is a close-up of those scales. So that is pretty dramatic. All right. Keratinization defects. Okay, 5 minutes before the break. Cool. So, keratinization defects, aka seborrhea. This can be in a primary seborrhea flavor, or it can be in a secondary seborrhea flavor. So basically, any condition that I'm talking about today, at some point in the age of that lesion, can lead to general scaling of the horse. So clearly, secondary seborrhea is far more common than primary seborrhea is. So you do a significant injustice to this horse if you see a horse with scaling, diagnose it with primary seborrhea, give them some shampoos and topicals and say you're good to go. Because in most cases, there is an underlying cause for the seborrhea that needs to be investigated. For a diagnosis of primary seborrhea to really fit with your horse, it should start at a very young age, because this is a defect in the keratinization process, so it should be something the horse is born with. If the horse has been carrying on for its entire life and has been fine, and suddenly at age 15 starts getting generalized scaling, you really need to think about what else is going on with that animal. So primary seborrhea, there are a few different patterns that are observed in the horse. You can see mane and tail seborrhea. You can see generalized seborrhea, and then you can see these localized forms. So linear keratosis, I'll show a picture of that one in just a moment. Cannon keratosis, that one is charmingly referred to as stud crud, and is a keratosis of the cranial aspect of the cannon bone. And of course, the differential diagnoses for that include the other causes for distal limb dermatitis, pruritus. So you diagnose this by clinical exam, biopsy. Again, the diagnosis of primary seborrhea only fits if the animal has been affected from a very young age. And then biopsy is necessary to get definitive diagnosis for primary seborrhea. And as I've said over and over and over, this might be a sign of an underlying disease that has to be investigated. So the picture here, I think it's difficult to appreciate from the picture, but you can kind of see that the horse's hair doesn't lay in the nice even way that you would expect a horse's hair to do. It's kind of clumpy. It appears to be maybe a little bit oily and greasy. Certainly is epilating a bit as well. So that's what you would see with a generalized form of seborrhea. This is linear keratosis. Linear keratosis is a keratinization disorder that is typically focal to the neck, shoulders, and basically starts off with these single little isolated hyperkeratotic lesions that gradually spread, and it usually doesn't become any more advanced than is shown in this picture. Treatment is not usually required. Sometimes these lesions can become secondarily infected, so a little bit of topical therapy and cleaning can do a lot, but there's not anything you can do to get rid of it. It's permanent, and it's just a pattern that you need to be able to identify. And then ulcers and erosions. Let's see. Well, let me do this slide, and then we'll be able to break. So ulcers and erosions, typically ulcers are going to be a progression of other problems that you're going to be identifying. So clearly pruritus can progress to ulcers and erosions just because self-induced excoriations, nibbling, that can lead to erosion of the skin. Irritant contact reactions can lead to ulcers just because of the chronic inflammation. And then the crusting and scaling lesions can also lead to ulcers and erosions because the skin under those crusts can be very ulcerative. And certainly deep bacterial pyoderma can lead to ulcers as well. But in addition to this, there are various autoimmune congenital disorders that can lead to ulcers, and there are also certain reaction patterns for different contact irritants that are common that you need to be able to recognize as well. All right. So perineal ulceration is one pattern that you need to be able to identify. Perfect. Come back in 15. Hello, everybody. Welcome back. One thing I wanted to mention before I go ahead and get started is that the format for the exam and for quizzing for all of this is pretty similar to what has been done for your small animal derm lectures. So there's a question bank, and you'll have access to the questions through the weekend to do these repeated, like randomly generated quizzes from the question bank. And then the exam is going to be also from that question bank. I think there are going to be 10 questions, and you'll have time on Monday. It was recently pointed out to me that right now the exam part is only the access is only available until I think like 5 on Monday, which was pointed out that might not be adequate for you guys. So I will make that longer so you guys can actually take it. That might be helpful. Yeah. Until Sunday night, it is the practice, and then they're two separate quizzes. So there's like the randomly generated one, which you can take unlimited number of times. That's through Sunday, and then there's the actual like 10-question exam part, which is Monday, starting like sometime early in the morning until currently 5, but it will be later. So, any other questions about that before we get started? Yeah. Correct. Correct. Yeah. Yep. All right. Good to go. And I will also send an email that kind of clarifies all of that after this. Okay, so let's talk about perineal ulcerations. So perineal ulceration is an irritant contact reaction that is caused by urine or fecal scald. You can see this horse here has a very dramatic example of perineal ulceration, just ventral to the rectum. This is usually due to poor management, and it can also be due to neurologic incontinence, frequent urine and fecal scald dribbling. So the treatment for it, gentle cleansing is the way to go. So just clean the area with warm, diluted chlorhexidine-based products that will cause relief for any local infections in the area, and will just gently clean, get some of the urine and feces off that area. And then you want to put some petrolatum jelly, basically just to protect the tissue. And systemic antibiotics are sometimes indicated if it's really deep, but usually because of the local nature of the infection, you can get away with just topical chlorhexidine. All right. So we'll talk about some of the mucocutaneous ulcers now. Mucocutaneous ulcers, trauma is a frequent cause of these. Drug reactions can also lead to this. And it's important to remember that with drug reactions can occur after a drug is administered for the very first time, or they can occur after a drug has been administered, hundreds of different times. And they can present with a variety of different lesions. So you can see generalized symptoms, generalized eruptions. Any body surface area can be affected, so it's not necessarily limited to the mucocutaneous areas. And then, of course, infection, vesicular stomatitis virus can lead to mucocutaneous ulceration. And then mucocutaneous pyoderma is kind of a somewhat uncommon variant of pyoderma, and it's limited to the mucocutaneous areas and is typically secondary to trauma in those areas. So in addition to those causes of mucocutaneous ulceration and ulcers, there are various congenital conditions that lead to ulceration. So epidermolysis bullosa is an inherited defect. It basically causes cleft formation with even slight friction or trauma. And this is a congenital problem. These horses are born with it. So you're going to see signs within just a few days of birth. So within 3 days, you're going to see these ulcers that develop typically at the pressure points. So you can see stifles by the hoof, by the elbows. And it's particularly a problem in Belgian draft horses. It is genetically mediated. So thankfully, there are genetic tests that are available through UC Davis. And unfortunately, with epidermolysis bullosa, there is no effective treatment. So if you have a horse that within a few days after birth starts losing parts of its skin. A biopsy is a good idea to rule out other causes, but the clinical presentation is often highly suggestive of this condition. Cutaneous asthenia is another inherited defect. This is basically a group of connective tissue disorders that the horse gets. Dogs can get it too, cats can get it too, humans can get it as well. Basically, it leads to very hyperextensible, very fragile skin. So you can see on that picture, a horse's skin shouldn't wrinkle like that, right? And that horse's skin, if you were to apply just a little bit more pressure, you could just pick that skin up and just take it entirely away from the horse itself. So what you're going to see are lesions that are in areas of friction and trauma. Even though these animals are born with these symptoms, sometimes with cutaneous asthenia, you don't actually notice symptoms until a little bit later in life. So it's sometimes common to see these at about 2 years of age when horses start training with bridle, tack, and saddle, when they develop these widespread ulcerations at the points where those things are applied. HERDA is one of the more common, is the more infamous, I guess, form of cutaneous asthenia, the most well-known. Stands for hereditary equine regional dermal asthenia, so you can see why we just call it HERDA. It's a problem in quarter horses, and there is genetic testing available, again, through UC Davis to identify carriers for that. HERDA has an autosomal recessive mode of inheritance. Bullous pemphigoid. Thankfully, bullous pemphigoid is very rare. This is an autoimmune condition that is caused by autoantibody formation directed against components of the basement membrane. So you get these ulcers and crusts that can be in the mucocutaneous areas, but they can also involve the GI tract. You diagnose this by biopsy, and the treatment, in theory, the treatment would be immune suppressive doses of steroids. So again, prednisone at a 2 to 4 milligram per kilogram dosage. However, that said, there have yet to actually be any successful treatment outcomes with this condition. So if you diagnose it, it's probably going to be fatal. And then erythema multiforme. So erythema multiforme is an uncommon acute skin eruption. The lesions can be either urticarial, so this is actually a really important differential diagnosis for urticaria and wheals in a horse, or it can be vesiculobullous, and it can be any combination thereof. The exact pathogenesis is not known, but it tends to be drug-related, particularly sulfa drug-related. So ways that you can differentiate erythema multiforme from true urticaria are that the wheals of urticaria will not pit upon pressure. And typically, the erythema multiforme wheals will persist for days to weeks. So again, true urticaria should go away in most cases within a few hours, but this will not. And so the way to differentiate, of course, would be to do a biopsy. And here we have a picture of a horse with erythema multiforme. So you can see that it is very, very similar in appearance to true urticaria. Let's move on to lumps and bumps. Oh, and one thing about erythema multiforme. In mild cases, it's self-limiting and will go away. In more severe cases, you might need to do supportive care. And in the absence of contraindication, steroids would be the way to go. But again, you need to figure out what the underlying inciting event was for it. So now let's talk about the various lumps and bumps that horses get. So this is where we'll be headed, and we'll talk about sarcoids. So do not confuse equine sarcoids with sarcoidosis. Sarcoidosis was one of the things that landed on the cutting room floor, so there's a little bit of info about that in the notes, but we're not going to be talking about it in lecture today. Equine sarcoid is the most common skin tumor in the horse. It is bovine papillomavirus associated, and the equine sarcoids are any age, any breed can be affected. Most animals tend to be between 1 and 7 years of age, and Appaloosas and quarter horses are overrepresented. This might be because these are the horses that are often found on cattle farms, and because this condition is associated with bovine papillomavirus. So there is the possibility for fly vectors being involved. Bovine papillomavirus has actually been found in flies, so it's entirely possible that flies are spreading that virus around, leading to equine sarcoids. And so here we have an image of just a little sarcoid. They have very variable presentations. There are 6 different types of them. Basically, if you ignore the mixed category, when you go from occult to malevolent, that's increasing in order of malignancy. So sarcoids, they do not metastasize, but they can be very locally invasive. And they can progress from a more benign form to a more malignant form. And one of the things that can lead to that progression is trauma. So trauma, inflammation. So the question then is, do you biopsy? Do you not biopsy? There's a fair amount of controversy, I would say, about what is the correct diagnostic protocol for these. The consensus is that if you are going to act upon the results of the biopsy, so if you're going to remove it, if it's indicated, then there's no contraindication to biopsy. Go ahead and find out what it is, and then actually act upon those results. If your owner tells you that no matter what the mass is, they're not going to be removing it, that's probably a mass that you don't want to be biopsying, because if you have an occult or varicose sarcoid, you run the risk of turning it into something that is really nasty, like the malevolent form. So the treatment of choice would be surgical excision when possible. Unfortunately, these are not always amenable to surgical excision based upon either the location or the severity of the mass. So things that have been reported to be successful besides surgical excision, intratumoral injection of cisplatin has been reported to be successful. There's a little bit more detail about that in your notes. And then imiquimod and bloodroot, so trade names Aldara and Xterra, have also been reported to be successful. So imiquimod is a drug that is used to treat human genital papillomas, and basically you apply these ointments onto the lesions at frequencies that vary depending on the medication. They both have a very high success rate. So the success range between 85 and about 92% success for both of those treatment protocols, and they have a response rate of, a treatment duration of usually between 6 to 10 months. So in areas where you cannot do surgery, maybe on the face, certain parts of the distal limbs, those would be good options for reducing the size. It's important to remember that no matter what treatment modality is employed, recurrence is a very common thing that you see. So here you can see another example of a sarcoid. So common places that they like to show up are on the face and on the limbs. So moving on to other papillomas. So equine papillomatosis is caused by equine papillomavirus, in contrast to the sarcoids. And it has this very classic warty appearance. So the lesions are typically on the muzzle, on the extremities. You can see it looks just like a wart, basically. Definitive diagnosis would be by biopsy, but they have such a classic appearance that in most cases, biopsy is not undertaken. For solitary lesions, surgical excision can be curative. They'll often spontaneously regress on their own, and because they are asymptomatic, in most cases, treatment is not actually attempted. And another form of equine papillomatosis are the aural plaques. As you can see here on the concave aspect of this horse, the very characteristic plaque lesions. These, in contrast to the other form of equine papillomatosis, will very rarely regress. However, these are also asymptomatic, so they're not more prone to developing infection. They're not going to be undergoing malignant transformation. So because of that, it's very reasonable to just do benign neglect. It's just an aesthetic sort of problem, so you can just deal with it, basically. However, imiquimod Aldara, which has been used for sarcoids, has also been used successfully to treat equine oral plaques. So you basically take this cream, apply it 3 times a week on an every other week basis, and that resulted in resolution of all of the treated oral plaques. And there was a relapse rate of only about 8%, which is pretty good. Many of the horse owners that had relapses, though, chose not to retreat their horses. The reason being that imiquimod actually causes a lot of local inflammation, and the procedure to apply the medication is actually fairly painful. So you basically need to take the crusts off, apply this medication. Obviously, taking the crusts off these lesions is painful. Applying the medication is painful. So many of these horses required general sedation when this was done. Eosinophilic granulomas. These are the most common non-neoplastic nodular growth in the horse, and they are, in some cases, associated with hypersensitivity disorders. Yeah, go ahead. Yeah. That's a very good question. In most cases they regress, and it's not usually of very much clinical significance, so I don't think in most cases you do much in the way of segregation of it. Yeah. Okay, eosinophilic granulomas. So these are often associated with hypersensitivity disorders. You would do a biopsy for definitive diagnosis of this. Aspiration of these lesions is often unsuccessful because it's just difficult to aspirate them. When you do aspirate, you're going to find eosinophils, macrophages, lymphocytes, as you would expect from an eosinophilic granuloma. And they can occur in singular or in multiple forms. And the treatments for them are steroids can hasten resolution of these nodules. If there is any evidence of a hypersensitivity disorder as an underlying cause, you should address that because in many cases that will improve these granulomatous nodules. So you can see here, this horse has obviously multifocal eosinophilic granulomas throughout the shoulder. So we're going to move on to some of the infectious causes of lumps and bumps in the horse. This is not obviously an exhaustive list. There is a very nice list in the Equine Derm book. We're just going to touch on some of the more notable ones, I guess. So Corynebacterium pseudotuberculosis. This is the cause of pigeon fever, which are pectoral abscesses in the horse. And there might be a fly vector involved. It's not exactly known, but it is suspected. And Corynebacterium, the infections in the horse are kind of like casus lymphadenitis in the sheep. So surgical drainage with thorough lavage that's the mainstay of treatment. When that's not possible, long-term antibiotics have been successful, but again, surgical lavage is the ideal if possible. Sporothrix schenkii, that's the image here on the right. This is a fungal cause of infectious granulomas. Leads to these masses that tend to follow lymphatics, so it's called lymphatic cording, and it's usually found on the distal limbs. And the treatment for this is with iodides. When you're treating with iodides, you have to watch for iodide toxicity. So that includes salivation, scaling of the skin, general lethargy. Basically, if you see any of those symptoms, you just need to stop treatment for a few weeks and then reinstitute at a lower dose. And then Pythium is a protozoal cause of abscesses and granulomas. Has all sorts of colorful names like swamp cancer, swamp leeches, kunker. And this is a very aggressive condition that without treatment is usually carries a grave prognosis. So surgical excision is always the best thing with Pythium if possible. Often the lesions are not amenable to surgical excision because they are either on the ventrum or distal limbs or on the muzzle. And in those cases, there are some immunotherapeutic vaccines that are available. Here's a picture of Pythium. There are some immunotherapeutic vaccines that are available that have been shown to reduce the size of the lesions. These vaccines don't produce any kind of lasting immunity, so it's not going to prevent the horse from getting pityiosis in the future, but it can make the size of these shrink down to something that actually is amenable to surgical excision. So with all of these conditions, they all can look very similar grossly, obviously. So culture, biopsy is the way that you're going to be able to differentiate all these various causes of lumps and bumps. Clearly, the infectious causes of lumps and bumps are treated in widely different ways than the non-infectious causes like eosinophilic granuloma. So it is important to do a biopsy and do a tissue culture to make sure. So that's a lovely, lovely picture. And one thing about pitheosis, the leeches that we talk about with pitheosis are actually these necrotic calcified foci that will kind of pop out of the lesions. So that's one thing that pitheosis has that I guess these other granulomatous conditions don't have. Those are the swamp leeches. It's lovely. And typically this is more of a problem in the south, but we can see it up here as well. And here's the pitheosis organism on microscopic examination, staining. So move on to habernemiosis. So habernema larvae induce this hypersensitivity reaction in the horse. And it's the hypersensitivity reaction that leads to these inflamed granulomatous lesions. Typically, you're going to see lesions on the legs, the prepuce, and the medial canthus of the eye. These habernema larvae are actually transmitted by flies. So basically the flies, when they feed on, or when they land on a part of the horse's body where there's maybe an open wound or any kind of exudate, that's when these larvae are deposited and then elicit this reaction. So it's important to remember that these are differential diagnoses for these lesions. But in addition to that, you can actually have habernemiosis superimposed upon any of these conditions, because certainly if you have, a neoplastic condition or proud flesh or an infectious granuloma, flies are obviously going to be attracted to that. So it's entirely possible that habernema larvae will be deposited on top of any of these other lesions. So the way you diagnose it, again, culture, biopsy. In rare cases, you can actually see the habernema larvae on direct cytology, but not in most cases. And the treatment for it is systemic ivermectin and then topical or systemic glucocorticoids. The steroids in and of themselves will often cause resolution of lesions, but again, it's important to rule out the various infectious causes of habernema. And so here we have a lovely example of habernemiosis. And exuberant granulation tissue, aka proud flesh. So horses are uniquely prone to developing these proud flesh lesions. These are just excessive granulation tissue that fails to epithelialize properly. And again, you want to biopsy it, you want to do culture to make sure there's not something infectious present. The treatment, I'm not going to go into too much depth. Obviously, this is the domain of surgery, but basically you do surgical excision and then bandaging. And in most cases, you can actually prevent these lesions by just doing correct bandaging protocols. So you can see, the image, all of these granulomatous lesions look basically the same. You just have to kind of take my word that this is proud flesh and not habernemiosis or something else, because grossly they all look the same. And other lumps and bumps. Squamous cell carcinoma is the most common neoplasia of the eyelid and the external genitalia in the horse, and tends to be more problematic in light-colored animals related to UV exposure, basically. So this horse is unlucky. It is not a light-colored animal, but it did develop squamous cell. You can see by the eyelid. Squamous cell carcinoma, again, surgical excision is the best mode of therapy when possible. Radiotherapy and chemotherapy have been reported to be successful in squamous cell also. And melanoma is the most common neoplasia of the undersurface of the tail and perineal area. Most common in gray horses. It is a neoplasia of melanocytes. So you can have singular melanomas, you can have multifocal melanomas. This horse here, obviously, it's not on the perineal area, but you can see the very classic deeply pigmented melanoma lesions on the neck. One thing that's very interesting about melanoma is that About 2/3 of horses with melanoma at necropsy have clinical evidence of metastasis, but the reason for their death or euthanasia is usually not related to any clinical signs associated with the metastasis. So it's just an interesting little tidbit, I suppose. Surgical excision is best when possible. Chemotherapy and radiotherapy have not been reported to be successful with melanoma. And you would biopsy this. Many clinicians will forego that diagnostic step because of the very classic clinical presentation. Cutaneous lymphoma. So there are a few different ways that we classify cutaneous lymphoma. We can have the non-epitheliotropic form, which is characterized by solitary to multiple nodules, which this horse here has. Are you guys able to see that from? No? How do I do the lights? How about dimming medium? How's that? Is that better in general? Do you guys like that more? Sorry. Okay, so the non-epitheliotropic form is characterized by solitary to multiple nodules, as evidenced by this horse. And you can also get multifocal to generalized crusting dermatitis. This is the epitheliotropic form. And these forms are also seen in small animals as well. It's rare in the horse. You diagnose it by skin biopsy. This horse here, this would be another differential diagnosis for wheals or erythema multiforme. So again, skin biopsy would be the way to go because these obviously are not going to go within a few hours. They're going to persist. So skin biopsy is the way to go. And pseudolymphoma is this very interesting condition in the horse. So lymphoma, the biologic behavior of lymphoma is fairly expected in other animals. So it's progressive, it's usually not very responsive to treatment, and almost always uniformly fatal. Certainly that's how it is in the dog. And there are these certain horses that have every indication of having lymphoma based upon biopsy, clinical signs, but instead of having this progressive disease, they actually kind of wax and wane for years, and in some cases actually just resolve. So pseudolymphoma is this term that has arisen to explain these horses that you think have lymphoma, but the behavior of their condition doesn't really follow what is expected in other species. All right, let's move on to pigmentary abnormalities. So, photosensitization. This is an abnormal cutaneous response to light, and it is limited to white or light-colored skin. There are several different kinds of photosensitization that exist just in general, but in the horse there are really two types. So primary photosensitization occurs when a preformed compound is either ingested or comes into contact with the skin and leads to photosensitivity. And hepatogenous photosensitization occurs when breakdown products from chlorophyll lead to photosensitivity in horses that have liver failure. So about 25% of horses that have hepatic impairment will develop hepatogenous photosensitization from these chlorophyll breakdown products. Here we can see an example of a horse that has photosensitization. You can see crusting, painful ulcers of the distal limbs. It's easy to see in this case that it's limited to the light-colored areas, but other differential diagnoses would be the different causes of pastern dermatitis, so like chorioptes, dermatophilosis, dermatophytosis. So diagnosis, history, physical exam, and you should always perform liver function tests because you want to make sure that there is not hepatic impairment. And for treatment, you want to determine and eliminate the offending agent if possible. So what that might involve is a little jaunt around the property to see what kind of flora is in the environment. Obviously, it seems intuitive, but you want to limit exposure to sunlight. If there's hepatic involvement, the prognosis is obviously more poor when there's hepatic involvement, but symptomatic treatment would be indicated. And then Antibiotics are indicated if there's severe, bacterial infection superimposed upon the photosensitization. In most cases, it's not necessary, though. Cutaneous vasculitis. This is primarily an immune-mediated syndrome. Classically is referred to as the type 3 hypersensitivity, which is caused by deposition of antibody complexes that lead to these symptoms of purpura. So purpura means purple. These are the lesions that are between petechia and ecchymoses. So it's kind of middling sort of size of purple lesions. You can also get wheals, edema, papules, plaques, necrosis, and an ulceration in more severe cases. It's important to keep in mind that this is a reaction pattern. So there are many possible triggers for cutaneous vasculitis. So again, thorough history, thorough physical exam to try to identify what set it off is of extreme importance. Biopsy is indicated. The tricky thing about biopsy when it comes to cutaneous vasculitis is that if you biopsy young lesions, you can sometimes see histologic evidence of vasculitis, so inflammation of the blood vessels. But if you have chronic lesions, you're not going to see any of that vasculitis, any of that inflammation. You're only going to see, at most, evidence of ischemic damage. So vasculitis is one of the more tricky things to diagnose. And in the absence of contraindication, corticosteroids would be the treatment of choice. So the most common, the most well-known form of vasculitis in the horse is purpura hemorrhagica. And you get purpuric lesions of the mucous membranes, the pinnae, and the distal limbs. And purpura hemorrhagica is typically associated with strep equi infection and has also been associated with strep equi vaccination. So you can see this little guy here has the classic signs of strangles. What happens basically is that a horse will develop symptoms of strangles, swelling of the lymph nodes, maybe upper respiratory signs, and then usually it's 2 to 4 weeks later that they develop the vasculitis lesions. So the treatments for purpura hemorrhagica would include steroids, but also antibiotics to make sure that strep equi infection is taken care of. So here you can see the very classic purpuric lesions with this. Leukotrichia. So if you guys have kept up with your classical languages, you would know that leukotrichia means white hair. There are a few different forms of leukotrichia that exist in the horse. It's common for leukotrichia to develop secondary to trauma, and so spotted leukotrichia, often caused secondary to trauma, is most commonly seen in thoroughbreds, Arabians. Basically, you get just these little spots of white hair. They are asymptomatic. There's no treatment that is going to get rid of it. It's just something that you have to be able to recognize. Biopsy is of limited utility because it usually has a rather classic appearance. I'll show pictures of spotted and reticulated in just a moment. And so reticulated leukotrichia is thought to be drug or vaccine associated. Basically, you get these cross-hatched crusts, typically over the dorsum of the animal. They can be a little bit painful. Once the crusts heal, the hair that regrows is all white, again, in this cross-hatched sort of pattern. And then hyperesthetic leukotrichia. These have a 1 to 3 month course, and you can have solitary to multiple, exceedingly painful crusts, typically over the dorsum. The crusts, after about 1 to 3 months, they heal, the pain resolves, but then the hair that regrows there is white, and again, the same is true of this form. There's nothing that you can do for the condition after it has caused the white hair. There's nothing that's going to get rid of it. It's just an aesthetic concern. So there, spotted leukotrichia on the left, and you can see the crosshatch pattern of reticulated leukotrichia here on the right. And then leukoderma means white skin. This is the loss of pigment to the skin, and this can be secondary to trauma. Autoimmune conditions can also be idiopathic. So one of the more notable forms of leukoderma in the horse is vitiligo, Arab pinky syndrome. This is a autoimmune condition that exists in the Arab horses, characterized by anti-melanocyte antibody formation. So it's inherited. Age of onset is 1 to 2 years. There is no effective treatment. You basically want to keep these horses out of the sunlight. You don't want them exposed to too much UV light. And various authors have recommended that these animals not be bred. So you can see this horse here. It looks almost like a cow, the picture, but you can see the white skin around the eye. And that's typical for what you would see with Arab pinky syndrome. And hyperpigmentation. So lentigo are non-palpable black spots. So the plural are lentigines. And these are most common on the muzzle and the mucocutaneous junctions. So if anybody has an orange cat at home, look at that cat's mouth and you'll see lentigines all over the mucocutaneous areas. Basically, these are just something that you want to recognize because sometimes owners will notice them suddenly and become very concerned that it's something cancerous. So you have to reassure them, no, it is not cancerous. It's just lentigo, no big deal. You can't do anything to treat it. It's not a big deal. And then, of course, chronic inflammation in the horse, just like in other species, can lead to hyperpigmentation of the skin. And this is secondary to any pruritic or inflammatory disease with chronicity. Then hair coat changes. So hair coat changes can occur because of pruritus, so self-induced. It can also be due to underlying systemic illness, changes in nutritional status, or changes in UV light exposure. So you can guess probably from this picture that nutritional status is probably at least part of the issue with this horse. And evolution has worked such that if there is a increasing nutritional demand on a horse, that the first thing that gets shunted away from is the skin. I don't agree with it, but that's just how it is. So effluvium is a form of hair loss that you see in the horse. There are two forms of effluvium. This is basically just widespread hair loss that you see. There's anagen defluxation and there's telogen defluxation. And so both are caused by acute illness. The difference is that with anagen defluxation, that acute illness only causes an interruption in the hair growth. So you interrupt the hair growth, but then it continues onward. And basically, the hairs all break a few days after the inciting event because the hairs are all weak at the point of where their growth was interrupted. So when you examine these hairs under the microscope, it's called a trichogram, you're going to see irregular dysplastic hairs. And then in contrast, telogen defluxation is caused, again, by acute illness, but instead of causing just interruption, it actually causes abrupt cessation of hair growth. So what you're going to see is 1 to 3 months down the road, there's going to be widespread hair loss. The hairs that are shed on trichogram are basically going to be regular looking. They're going to be uniform looking, a very slightly clubbed root, so it's going to be very typical of just a telogen sort of hair. So both of these conditions are common in foals after illness. So it's just something to recognize and be able to kind of fit on the timeline in your head. Yeah. Yeah. Yep, you just pluck the hairs. It's helpful to put it on a little bit of mineral oil just so the hairs aren't going all over the place, but just putting on a slide, looking under the microscope. Yeah. So here's an example of effluvium. You can see the widespread hair loss there. Oh, yeah, sorry. Trichogram, to clarify, is just examining hairs under the microscope. So on some mineral oil on the slide under the microscope. Alopecia areata. This is immune-mediated destruction of hair follicles characterized by well-demarcated, non-scarring alopecia. It can be focal, it can be generalized. Diagnosis based upon history, physical exam, and then skin biopsy. In chronic cases, what you're going to see is just the complete absence of hair follicles. In more acute cases, you can actually see inflammation of the hair bulbs. And there is no treatment. There have been some kind of anecdotal reports of steroids maybe having some success, but there are no definitive treatments that I can really recommend for this. And here's an example of alopecia areata. You can see the well-demarcated, kind of patchy alopecia that you see with this. And then retained hair coat. This can be due to poor health, poor management, or underlying systemic disease. I'm not about pituitary pars intermedia dysfunction too much because you'll get a lot of that with Dr. Darian and his endocrinology notes. But that is one of the big causes that you'd be thinking about with retained hair codes. So that gives me 10 minutes, which is pretty much where I want to be. So thank you very much to everybody, and also to Dr. Kunder and to my students for listening to me talk over and over and over. And then I do have some evals for you guys to fill out. So I am just going to start these here. There's a top sheet, there's a bottom sheet. It says Dr. Moriello on it, but I am not Dr. Moriello, as you might have guessed. And I'll be here for questions.